All right, let's do this. Today, you're not just watching, you're in the hot seat. We are simulating a high-stakes general surgery viva exam. You are the candidate. Your career is on the line. Let's begin.
Okay, take a deep breath. The examiner has just given you the opening line, and right away, your alarm bells should be ringing. This isn't just a neck lump. That hoarseness of voice, that's a huge red flag right from the get-go. The clock is ticking, and they're waiting to see your structured, logical approach. So here's our game plan. We're going to tackle this case exactly as you would in the real exam, moving from history and examination through to diagnosis, the surgical plan, and of course, how to handle complications. Let's dive in. Okay, my turn. The key is to stay calm, stay structured. I'd start with something clear and confident, like, thank you. I would begin by taking a thorough history. This is where you build your foundation and show the examiner that you're thinking like a clinician from the very start. I'd start by getting the details on that swelling. When did it start? How quickly has it been growing? Then I'd ask about any compressive symptoms, things like difficulty swallowing or shortness of breath. But the most critical point to explore is that hoarseness that immediately makes me think about potential involvement of the recurrent laryngeal nerve. After that, I'd screen for any symptoms of an overactive or underactive thyroid, and of course, I'd have to ask about major risk factors, like any prior radiation to the neck or a family history of endocrine cancers. In this scenario, the patient confirms that, yes, the swelling has been getting progressively larger. Okay, after the history, it's straight to the physical exam. I tell the examiner I'm going to perform a focused neck examination. Stand behind the patient, have them relax their neck muscles, and feel the thyroid gland as they swallow. And here's what I'd find. A large, hard, ill-defined mass on the right side, maybe 6 by 5 centimeters. Then I do a systematic palpation of the cervical lymph nodes, and yep, I'm feeling multiple hard and large nodes in the right lateral neck. You put that all together, a hard, fixed mass with palpable nodes, that is highly, highly suspicious for cancer. The examiner nods, seemingly satisfied, but then they hit you with the next question. Good. What is your differential diagnosis, and how will you confirm it? This is your chance to show you can think broadly while still zeroing in on the most probable cause. Well, based on the findings of a hard, fixed mass with hoarseness and cervical lymphadenopathy in a 57-year-old male, my primary diagnosis is, without a doubt, thyroid cancer. But you can't just stop there. My differential would also include a multinodular goiter, though it's less likely given the hardness in the nodes, and you always have to consider the rarer possibilities like parathyroid cancer or even lymphoma. To confirm the diagnosis, I'd lay out a clear, stepwise investigation plan. I'd start with bloods, including thyroid function tests and calcium levels. The key imaging here is an ultrasound of the neck to characterize that nodule and the nodes. That ultrasound will then guide the single most important step, a fine needle aspiration biopsy. And I'd be very specific. We need to biopsy both the primary thyroid nodule and those suspicious lymph nodes. Because of the hoarseness, a laryngoscopy to assess the vocal cords is absolutely mandatory before any surgery. And finally, we'll need a CT scan of the neck and chest for staging. So the first result comes back. The TSH is normal. This is a classic exam pitfall. It's so important to state that the majority of thyroid cancers are actually euthyroid. A normal TSH does not rule out malignancy at all. Next, the ultrasound report. It shows a large hypoechoic nodule with macrocalcifications. When you see those words, you should immediately be thinking cancer. The report also confirms multiple enlarged lymph nodes on the right side, which strongly suggests metastatic spread. And then the final piece of the puzzle, the FNA cytology. It confirms the diagnosis, papillary thyroid cancer, with metastatic cells found in the lymph nodes. So we now have a tissue diagnosis of locally advanced thyroid cancer. The game has completely changed, and we are now moving from diagnosis to management. The examiner leans forward. This is the core of the viva. Now that you have the diagnosis, how will you manage this patient? They don't just want to know if you can operate, they want to know if you are a safe and competent surgeon. My management wouldn't start in the operating room. It starts with discussing the case in our multidisciplinary team meeting. After that, I would sit down and communicate the diagnosis and our plan with the patient and his family. The preoperative laryngoscopy has already confirmed that the right vocal cord is immobile, which is a critical finding that's going to heavily influence our surgical plan and the consent process. Only after all that would I obtain comprehensive informed consent before admitting the patient and starting our standard pre-op protocols. The proposed operation for this patient, given the confirmed nodal metastasis, is a total thyroidectomy with a central neck dissection and a right modified lateral neck dissection. You have to be precise with the name of the operation. It shows you understand the full extent of the surgery that's needed. Now, during that consent process, I would really have to emphasize the specific risks for this case. With the right vocal cord already paralyzed, the single biggest risk is injury to the contralateral, the left, recurrent laryngeal nerve. If that were to happen, it would result in bilateral vocal cord palsy, a true airway emergency that would require a tracheostomy. I would explicitly tell the patient about the high possibility of needing a tracheostomy postoperatively. Of course, you'd also cover other key risks like permanent hypoparathyroidism and bleeding.
The surgery is done. You think you might be in the clear, but the examiner's not done with you yet. They throw a curveball. This is designed to test how you manage complications when you're under pressure.
The examiner looks at you. Candidate. It is post-op day 1. Your patient is complaining of spasms in his hands and tingling around his mouth. What is happening, and what is your immediate plan of action?
Those are the classic symptoms of hypocalcemia. It's likely due to iatrogenic hypoparathyroidism from either devascularizing or inadvertently removing the parathyroid glands during that extensive dissection. This is a recognized and very serious complication.
My immediate management would be to check serum calcium and albumin levels stat, but I wouldn't wait for the result. I would immediately administer intravenous calcium gluconate to stabilize the patient. Once they're stable, I'd start high-dose oral calcium and active vitamin D, and we would need to carefully titrate the dose based on their serial calcium measurements and how their symptoms are responding. And of course, long-term follow-up is absolutely critical. This patient will require lifelong thyroid hormone replacement, with a specific goal of suppressing his TSH down to between 0.1 and 0.5 to reduce the risk of recurrence. Surveillance will involve checking the tumor marker, thyroglobulin, along with the neck ultrasound every 6 to 12 months. And finally, based on the final pathology report, he would almost certainly be considered for adjuvant radioactive iodine ablation to clean up any microscopic disease.
And just like that, it's over. The examiner says, "Thank you, candidate. We've successfully navigated a very complex case." Now, let's step out of the role play for a minute and distill what made that performance a success. Success in a viva isn't just about knowing facts. It's about demonstrating safe, logical thinking. You have to be structured. You have to emphasize patient safety at every single turn. You need to communicate clearly, and you have to anticipate complications before they happen. But most importantly, be ready to justify every decision. Why that investigation? Why that operation? Why that follow-up plan? You have to have a reason for everything you do. And that leaves us with a final thought. The Viva exam is more than a test of memory. It's a simulation of reality, and it's asking a fundamental question every surgeon has to answer. Beyond just reciting the steps from a textbook, how do you truly demonstrate sound surgical judgment and an unwavering commitment to patient safety when the pressure is really on?